From coast to coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people who call this land home. The Canadian Federation of Nurses Unions is located on the traditional unceded territory of the Algonquin Anishinaabe people. As settlers and visitors, we feel it's important to acknowledge the traditional custodianship of these lands, which we each call home. We do this to reaffirm our commitment and responsibility in improving relationships between nations, to work towards healing the wounds of colonialism, and to improving our own understanding of local Indigenous peoples and their cultures. Miigwech.
Bonjour, everyone. I'm Linda Silas, National President for the Canadian Federation of Nurses Union. And it's such an honor and it's so touching to be dealing with this subject today, to be dealing with racism in our healthcare system. We've been working on this presentation for a long time. And before I go any further, thank you to all, to our three guests, and we'll get to them soon. As you know, this event is only in English. If you have any questions or comments, add them at the bottom in the chat line, and we'll make sure that we work to get your answers or get the information you need. Bonjour tout le monde, je suis Linda Silas. Comme vous le savez, toutes nos sessions sur Facebook Live sont seulement en anglais. Mais si vous avez des questions ou commentaires, s'il vous plaît, écrivez-les dans la section chat et je me ferai un plaisir de les répondre, soit moi-même ou un de mes invités. Alors, un gros merci. During the session, don't be shy. Ask your questions. Go further with your comments into the comment box, and we will. So today's issue we will be discussing is a very important issue, and it relates to the land acknowledgements we just heard. And it's more than acknowledging the traditional territories we live, we work, and we have our families on. It's going to the heart of what we've been seeing more mainstream media in the recent months of systemic racism in our society, but we'll focus on healthcare today. I'm honored to have three guests, Tanya Dick, who's a registered nurse in British Columbia, Dr. Samir Shahim Hussain, who's a pediatrician, emergency pediatrician in Montreal, and Dr. Raven Dumont-Maurice, who's a pediatrician also from Quebec. You'll hear a little bit more from them in a minute. But racism against Indigenous people is deeply rooted in our society and in our healthcare system, that we want to see it or not. While, as I said earlier, it has caught more mainstream media in the recent years, Tanya, who's a good friend of mine, a femter, and really a person who has opened my eyes over the last 18 years on what was happening in communities, in Indigenous communities in healthcare, and she'll tell her own story. But just before Christmas, she sent me the report in plain sight that was talked about, or was the commission that was done after an awful gaming in BC emergency rooms. And purposely, I didn't read it during the holiday period because I knew it was going to be hard. But this weekend, I took the weekend to read 238 pages of stories, of realities, of what was happening in our healthcare system. It also was amazing to go through the history. And, you know, it started in the 1930s and even earlier than that. And you think 1930s, even some of you are saying 1960s, the 60s scoop. That's so far away, Linda. You know, how can we even be responsible for that? You will see when you read the report, key dates in 1964, 67, 1999. 1999 was the year where Jordan River Anderson was born in a little, he was born in Winnipeg, but he's from a little Northway community in Manitoba. And he stayed 2 years in the hospital, and he stayed 5 years in the hospital, but after 2 years, he was deemed okay to go back in his community. And And nurses from Winnipeg really got touched by this story because the federal and provincial and territorial, but mostly federal and provincial governments were more or less fighting who would pay the bill for home care. That young boy stayed in the hospital until his last breath at the years of 5 years old. That created a big turmoil in our country. And it took 5 years. It took until 2005 for the federal government to create the Jordan Principle. You'll hear tonight about the Joyce Principle. And when I first read about the Joyce Principle, it brought me back to Jordan. It brought me back to 2005 when CFNU signed on to campaign and lobby every MP since 2005 to work with Cindy Blackstock, one of my she heroes. We worked with her when she wasn't that famous. But looking at how, as nurses, we can make a difference for Indigenous children getting help. Well, 2020, they were still fighting in the courts. Now we got that resolved, not we, but the Caring Society got that resolved, and hopefully it will work. But it's to show that when we're talking about injustice, when we're talking about racism, it's yesterday. The Joyce example was last September. We have to realize that when we're talking about racism, when we're talking about the injustice in Indigenous community, when we're talking about the water boil advisory in over 100 communities, these are real. These are today. They're not the history books. I was stunned to hear that the last residential school was closed in 1996. 1996, that seems like yesterday. Anyway, I could go on and on and on, but I won't because we have 3 experts and we'll go there. Today we won't be talking about Indigenous women, Indigenous girl, but I have to say we cannot forget about the missing and murdered Indigenous women, girls in this country. We have to remind ourselves that there are hundreds, if not thousands, still missing today. And it is part of the systemic racism where we forget. So let me start with my first guest, which is, as I said, a femter, a real expert, an eye-opener for me and for so many nurses across Canada, Tanya Dick. Tanya is a registered nurse. She has a master's in public health. She is from British Columbia, I mentioned, but her home is the Zawadahe First Nation of Kingdom Come Inlet. I was supposed to go there this summer, this summer, the summer of 2020, to visit your family and your community, and then COVID hit, but I'll get there. Tanya is the former president of the Association of Registered Nurses of British Columbia, a former member of the Canadian Nurses Association and the Canadian Indigenous Nurse Association. Tanya, please.
Hi, thanks, Linda. Thanks for having me. I'm really excited about the opportunity and the platform for this discussion. Nugua Makwalogwa, my traditional name is Makwalogwa. I'm from the Muskuma Tsaudeno people of Kinkam Inlet. As Linda said, I'm a registered nurse. I've been nursing for 18 years now. All of my career has been in Indigenous communities, Indigenous health, mostly, 98% in rural and remote. Really asked to come today and share my experiences and thoughts around kind of racism and anti-Indigenous racism and discrimination in our healthcare systems. For me in BC, but it's across the board, across the country. We see more and more of that percolating to the surface. We're hearing more and more stories. We're hearing more and more voice of people's coming forward. We're seeing more and more organizations and health professionals wanting to be a part of the solutions. So it's exciting for me to be able to, anytime I have the opportunity to speak to nurses, I'll jump on that for sure. I guess my racism and discriminatory experiences that I've had both personally and professionally have been all of my life. I, as an Indigenous woman, I could probably write a set of encyclopedias on my personal experiences of racism and discrimination within society and within kind of different institutions. But particularly when I was accessing education and I did my undergrad program, I did my nursing, and I did my nurse practitioner program with my master's, I experienced quite a bit of discrimination and racism as well. And I think just, to be really quick, and one of the worst experiences that I had in my undergrad program, I was in kind of my third year clinical setting, my clinical placement. My faculty member, she failed me basically and said I didn't belong there and I needed to go back to my people. And I think at the time when I was failed, and I was kind of thinking that I was a failure and I wasn't going to be a good nurse. I wasn't in that fight mode or advocacy mode. I was just like kind of took the legs out from underneath me. But I look back on it now and I'm really grateful that people that were in positions of power or decision making heard the story and said, let's put her in another clinical setting. So I got to do that move over and kind of aced it. And I'll never forget that experience of kind of being judged and kind of labeled as less than and didn't have the capacity and I didn't belong and I needed to go back to my people and stay on the reserve, basically was what was told to me. And I still, that scar is always really visible to me every day. It impacts and affects how I approach things in the world, and really cautious. And then when I went into my master's program, we're now 5-6 years into my career. I immediately had been involved in the union here in BC at the BC Nurses Union, was really taken up and really built up and given opportunity and exposure and education to be a strong activist and, have the skill set and language to be able to advocate for certain things. So I felt really strong going into the master's program and immediately thought, you know what, I know there's Indigenous undergrads in the School of Nursing down the hall from me. I approached the head honcho, I went right to the top and said, what can we do? Like, I'm willing to be a mentor. I live on campus. I am here in this bubble for 2 years. What can we do to help make this experience for Indigenous nursing students to be a success? And was told right out, no, you can't do that. We won't have you do that. And then kind of pushed it a little bit. And then, she said, we don't have Indigenous students. And I'm like, oh, what? Okay, so how can we go about getting more Indigenous students? And I just kept pushing and pushing the agenda. And finally, it was like, okay, this is not an issue. This is a non-go issue. We are not going to do that. We're not going to encourage Indigenous people to come into this program. And we're not going to create these mentorship programs. So like, shut up and go away. She didn't say that in those words, but she was very, very vicious about it and kicked me out of the office and didn't want to be a part of kind of building that capacity within Indigenous nursing. And, I'll never forget that. And that whole system under one or two people is not, when it's not kind of on track to kind of help build numbers of Indigenous health providers. I didn't know where to go with that. So that was a real eye-opener for me that it was a hard no and there was kind of no other way around it. Kind of left the room and left the floor with my tail between my legs and not able to kind of influence and help. I continue to be a part of that institution and I continue to push the agenda. We now do have influenced some changes systemically within that program to encourage Indigenous nursing students to apply and get into the program and provide some supports around them to have some success and graduate and maintain, stay within the career. Because I think through the 18 years that I've been in practice, particularly the first 10 years, really paying attention and kind of trying to find as many Indigenous nurses as I can across the country, it was shocking to me the amount of Indigenous nurses that made it through the program, that graduated, and then the attrition rate of them actually leaving the career just because of the experiences that they were facing, both racist and discriminatory on the floor or in their jobs or just within the profession itself, was alarming to me. So continue to tackle that one. My most personal racist and discriminatory experience I had within the health system, back in 2008, I think it was September, we heard the media come out with the Brian Sinclair story in Manitoba, who, the man died a preventable death in Emerge, was assumed to be under the influence and needed to sleep it off, was a drunk Indian. It was in September March, actually. So it was before Brian Sinclair's death that my Auntie Deb, my mom's sister, had, she was home. She had slipped, fallen, hit her head on the bathtub in the bathroom. Her husband brought her into Emerge. She was inputted into the system as ZTOH, so she was under the influence. She was Indigenous. They tucked her away in a bed, let her sleep it off, but she just continued to escalate in her behaviors. Long story short, they couldn't handle her and Emerge, so they called the cops. They threw her in cells. She got sicker and worse, and the ambulance crew came back to get her and bring her back to Emerge because RCMP was concerned. She wasn't able to kind of walk and hold her own, so the ambulance crew kind of put their arm under her arm and dragged her out, and her knees were kind of dragging out, threw her in the jump seat, and got her back to Emerge. She eventually died about 15, 17 hours in, and had a full coroner's inquest, and she had 0 alcohol and drugs in her system. She died of a result of a head injury. And when we did all of the interviews, and the coroner went through all of these interviews, and we kind of broke it down every minute that she was in the system, she passed through the hands of 17 physicians, nurses, LPNs, care aides, RCMP, BC Ambulance, a stranger, and every single one of them had the assumption that she was just a drunk Indian and didn't go that extra step to do a basic assessment that could have prevented it. And when the neurosurgeon and the doctors in Victoria, where she was brought down to, said that if she had there was enough time and she had the appropriate care, she'd still be with us today. And, that's the hardest thing as Indigenous communities and families, the matriarchs and the women, especially our aunties, are just like our mothers. And to have somebody so close to me taken away so unnecessarily and preventable, and just, I watched my mom completely crumble with that one. My mom's a nurse as well. She was a nurse. And when she heard and sat through that whole coroner's inquest and heard how my aunt was treated, she just crumbled before my eyes, and she's never kind of rebounded from that and come back from that. So that was difficult to watch. And so that was the biggest one. And, when it comes to 2020, and our Minister of Health here in BC heard a story that in the Emerge department, somebody was playing a game, and, the staff were kind of trying to guess the alcohol level of Indigenous people was what was the tipping point for the investigation to happen with Mary Ellen Chappelle-Lafont and the In Plain Sight report. When I think about it, and I just was like, that's what caught your attention when these people are, our loved ones are dying, these preventable deaths, and under this kind of racial and discriminatory thought process is just beyond me. But you know what? I'll take it. The investigation happened, the conversation's happening, the recommendations have come forward. So that's kind of something that's happening in BC that's really kind of forcing the hand for all of us to take this on. And I've had the privilege as well working with the First Nations Health Council here in BC and being a part of a process where we're creating a standard under the Health Standards Organization out of Ottawa. And it's a cultural safety and humility standard originally for BC, but this is something that we want to see go across the board, across the country, because we're going to see and hear later this evening that it's happening all the time and it's kind of everywhere. When we created the standard, they created a technical committee, and the composition of that were, there was 4 main stakeholders: policymakers, frontline providers, kind of researchers / academics, and kind of people with lived experience, so the patient voice, to create this standard. The standard that we are in the process of about a year and a half now, there's 8 items, 8 kind of themes. They cover key areas within the health system that need to change in order to address the racism that we're experiencing as Indigenous people, from the governance to the front line, including how to handle racist behavior and how do we collect data and information to inform anti-racism decision-making within the system. Our lead from HSO kind of describes it as the bricks and mortar that can support an anti-racism culture at the health system level. So that's an exciting process. We're going to be going to public review hopefully in the next couple months here. We're very close to it. And that's something that, I'm going to reach out to Linda and all of the heads of nursing unions, nursing associations, that we participate in that public review, because I think the nursing voice in this standard is going to be absolutely vital. I mean, we are often the first point of contact to patients, and we are most often the last point of contact as well. So we have a huge role in the shift. We have a huge role in kind of influencing this change, and really looking forward to it. I just want to add that even in 2008, in the hospital near where I work, where my aunt died unnecessarily, was 13 years ago. Just recently last week and the weeks before that, have been meeting with kind of health authority CEOs and management and leads, and about a youth who had died in the same hospital just recently, completely preventable, completely unnecessary. So it continues every day. It's not kind of just remarks that are hurting people's feelings. It's actually actions and decisions that are being made that are taking people's lives. So this topic and this issue is close to my heart, not only because of my personal lived experience and my loss and my trauma around it, but the fact that, I'm a nurse too. And I've always said I've had the two greatest prides in my life, that I'm a Musqueam woman and that I'm a registered nurse. And I know that as nurses, the numbers, and if we're organized and we're informed, that we can move mountains and we can really change the world. And I think when Linda was talking earlier about reading the report, and you kind of look at the history of it and how many documents and reports have been made through since contact, really, and they pretty much all have the same theme, and they all pretty much say the same thing. And it's time for someone and some of us to start breathing life into these documents. So if you have the in plain sight report and recommendations, let's not put it on the shelf. Let's take it to heart and take it back to our job, take it back to our floor, take it back to our union, take it back to our executive, and start looking at how we can weave these through our workplaces and work sites and environment. Because until that happens, we're just going to continue making reports. We're going to continue this conversation. My people are going to continue dying. They're going to continue being harmed. And that needs to stop now. We're at a point now where society is saying this is unacceptable. And I think we have so much influence and trust in society as nurses, that we need to utilize that and tap into that leverage to be able to influence this change, because I know we can, and I've seen it happen. And I'm just so proud and want the best for nursing as a profession. And this type of stain doesn't need to be on us. We need to be a part of the solution, and we need to fix it together. So those are kind of my thoughts around that. I'm constantly asked, what can I do? I feel like my successes and my capacity and my skill set, I really kind of was involved in the BC Nurses Union. And I've always said that I'm a product of my union, really built up and learned how to be an activist and advocate. I remember talking to Linda, and we brought to CFNU how we can try and push all of the provinces and territories to try and build the same sort of systems within, and lift up and build the Indigenous nurses and help them influence nurses within their provinces and territories. So I don't know, there's a million things we can do. I just I really appreciate the wave that's happening right now, and the opportunity, and really to look at it from just opportunistic perspective rather than a defensive perspective, because it's a really difficult conversation. Racism and discrimination makes us reflect on self and reflect on practice and kind of look in the mirror. And I can't remember where I was, but it was a really profound comment that somebody had said, I'm not calling you out, I'm letting you in. And I think that's really huge. This is really part of us kind of opening our hearts and souls. And we want everyone to be a part of the solution here. And we've always showed up as Indigenous people, and we just want better, and we deserve better. And we shouldn't have to legislate that. We should be able to just exist and be the best that we can be. And like Linda, I can go on and on and on too, but there are other people you need to hear from. I just really appreciate the opportunity to share my personal stories. I really am thankful for the space and you hearing me and seeing me. So really full of gratitude right now, and I'll stop there. So thank you very much.
Thank you. And when you go back, Tanya, and look at the Facebook Live, you'll see all the love and the positive comment showing your strength. I can't understand. I can understand. I can't apologize for all the personal hurt you went through, but I have to say thank you to those nursing leaders that told you you were too Indian, that told you to go back to your reserve, because that was a turning point, and we needed that in nursing. And now, 10 plus years after, you're still one of our strongest advocates, and that I have to say thank you to those. I won't swear on Facebook Live, but it was so important as a turning point. And we will work together on how to handle racist behavior, because it is gut-wrenching stories like you're telling us and personal stories that we're able to change behaviors, and we will do it, I promise. My next speaker is Samir, nice young physician from Montreal. He's also an adjunct or an assistant professor at the Faculty of Medicine in McGill. He says, Linda, I'm not an academic, I'm a clinician. And quite an amazing story. The story I have never met Samir, but the story that I read to look at a campaign from #Hands to Hold, which is all about children in northern communities that are flown to big cities all by alone without parents, and because governments didn't want to pay again, and how public pressure was able to change that. And Samir will explain that. There's one of my mentor, Kathleen Connors, who always says that politicians don't change policies because you convince them. They change policies because they feel the heat underneath them. And I think Samir was able to do that. So please, Samir, tell us your story.
Thank you so much, Linda. I also just want to thank everyone at the Canadian Federation of Nurses Unions who helped put this together, Julien, Tyler, and Lauren as well, kind of working backstage. I also just want to acknowledge Tanya's really powerful presentation. I feel it's always a bit difficult to speak after someone who's shared such an intense and very personal experience, and who herself has been a significant advocate and activist for change. So I'm very humbled to speak after Tanya. I've never met her, but her reputation preceded her, and I'm very humbled to speak after her. Like Linda mentioned, I'm a pediatric emergency physician at the Montreal Children's Hospital, based in Tiohtià:ke or Montreal. I just want to do a quick land acknowledgement for where I am. I'm located on unceded Indigenous lands. The Kanien'kehá:ka Nation is recognized as the custodians of the lands and waters where I live. Tiohtià:ke or Montreal is historically known as a gathering place for many First Nations, and today it is home to a diverse population of Indigenous and other peoples. And I'm committed to respect the continued connections with the past, present, and future in my ongoing relationships with Indigenous and other peoples within the Montreal community, and that's an adapted from the Concordia University's Indigenous Directions Leadership Group. Very quickly as well, I don't have any conflicts of interest to declare. But in terms of disclosure, I should say that I was asked to speak about my book, and one thing that is important is that I will not be receiving any of the royalties from the book. All of the royalties are going to pre-designated organizations in support of Indigenous children, youth, and their communities. And these are the the 6 groups that they're going to. I also want to acknowledge, even though it's my name that appears on the cover of the book, Cindy Blackstock, who needs no introduction, and Ellen Gabriel, who also doesn't really need any introduction, contributed to the book. Cindy wrote the foreword, and Ellen Gabriel wrote the afterword. And I feel it's really important to acknowledge their contributions because the book would not be what it is without the writing and their support over the years. I'd also like to just acknowledge, Linda mentioned, this practice essentially that existed in the province of Quebec since the 1980s of preventing caregivers from accompanying their children during emergency medevac airlifts. It's important to note that this was actually a practice that impacted kids across the province, regardless of whether they're Indigenous or not. But kids who were Indigenous communities, particularly those in northern Quebec, were the ones who were disproportionately impacted by this practice for various reasons that I won't be able to get into, but including social determinants of health and whatnot, and structural determinants of health. But clearly, Indigenous kids from northern Quebec were most impacted, and so that was one of the reasons why in our campaign we centered kids mostly from Iwi or Cree kids from the James Bay Cree communities, and Nunavik or Inuit kids from Nunavik. And so these are some of the families that spoke out courageously during the campaign, and without their interventions publicly, the campaign would not have been what it was. And so again, without going into all the details, basically we kind of launched the campaign after a lot of discussion with various team members in the emergency and the ICU, on the wards, nurses, social workers, physicians, clerks, orderlies, who had experienced these situations of these kids systematically being transferred to us alone, with their parents or caregivers often being forced to take the next commercial flight that was available, and sometimes that wouldn't be available for days after. And you can imagine this was happening up until 2018, when we finally managed to change this. So this is, as Linda was mentioning, this is not ancient history. This is now, basically. I mean, things have changed, but it took a lot of work, and it took a lot of fighting that communities had already been initiating since the 1990s. And since the 1990s, communities were trying to change this, and government and the government agency responsible had basically refused those demands for change. So I'm just going to go to, I'm going to ask Julien and Lauren just if they can run this video. It's a 2-minute video clip, which is a news report, basically, from the CBC from 2018. And it gives a bit of an update and an overview of the kind of the campaign in a nutshell. And I'll come back to discussing very quickly why I share this clip right after.
A rule that prevented sick children from traveling with their parents aboard medevac flights has been widely criticized in Quebec. After recent pushback, the government yielded and promised to let parents on board. At a community event at this mosque, the health minister was asked why that hasn't happened yet. CBC obtained a recording of his response, where he guaranteed someone intoxicated will be kicked off of a flight in the next 6 months.
That where someone will not be made allowed, not allowed to get on the plane. Why? Because no one agitated, drugged, under whatever influence would get on the plane. Any cost. That will not happen. And that happens all the time.
Those words led to a chorus of condemnation.
To have comments like that by a minister is totally appalling and unacceptable. We're going to demand that the minister resign from his position.
The head of an organization that represents Inuit in Quebec's north says he needs to apologize, and I don't think that will be enough. He needs to go. The trust is gone. Barrette backpedaled today, at first saying that people wrongly assumed he'd been talking about Indigenous people when he meant it more generally. Then, later, he offered this as an apology.
I can understand the sensitivity of that and the reaction, and I apologize for that.
I'm quite sorry about that, but at the end of the day, can we move on?
The Premier is standing in solidarity with his health minister as a provincial election looms.
I think he's sorry that his words have been interpreted that way. I suggest that we leave it there.
Barrett did call the mayor of Kuujjuaq to apologize. The mayor says he does not accept the apology. He's demanding that the minister resign immediately. Jayla Bernstein, CBC News, Montreal.
So if you just bring up the screen, perfect. Thank you so much. So there's a few reasons why I share that that video, and I can, to be honest, I could talk for an hour about all the issues. But they raise a few points, I guess, that I would like to address. One is that these comments were made very intentionally. The campaign had always centered Indigenous children from northern Quebec, and so when he made those comments, it was very obvious who they were targeting. But what was striking to me, and this comes back to one of the questions I was asked for this presentation, was kind of why did I write this book? And one of the reasons for writing the book was this incident, because it really highlighted the impunity with which someone can make these comments. This is, again, the context was, as we saw in the report, Indigenous leaders, activists, politicians called for his resignation, and that didn't happen. He completed his term as health minister up until October 2018 when the new elections happened. And that's impunity. And this is coming from a health minister. It's not it's not some like random person. This is the health minister who himself is a physician. He's a radiologist. And so that sends a very clear message throughout the province of anyone working in healthcare that, espousing these kinds of views and perspectives is basically acceptable. And so him being allowed to make these comments without getting afterwards, without being forced to resign, was really shocking, And at the same time, one of the opposition ministers was François Legault, who's now currently the premier of Quebec. He didn't say anything in the context of this controversy. And what's interesting is, even to this day, François Legault denies the very existence of systemic racism. And I mention, again, this example because this is another reason that motivated the book, because ultimately what we see is that, the non-accompaniment rule was an archaic, antiquated practice that could have been resolved almost with the snap of a few, of fingers. It took essentially a few months of pressure from the campaign for the practice to change and for them to institute a family and child-centered policy. So clearly, it was something that was easily changeable, but it persisted for years. But even during the campaign, there was this kind of constant, refusal to kind of do things in really a smooth way to understand the issue. And it's really reflective of how colonial governments essentially deal with Indigenous communities and their demands. Historically, Pamela Palmater, a Mi'kmaq scholar, legal scholar, kind of calls it, deny, deflect, defer techniques. And that's exactly what happened throughout the campaign. And so one of the other reasons for writing the book was, for me, it was just this question of this thing that's so simple, that was relatively simple, that was somewhat, I wouldn't say marginal, but was affected hundreds of kids, which is a huge deal, and that's why we launched the campaign. But compared to other issues, perhaps it's not as significant or severe an issue, and yet even for something as simple as this, it was an uphill battle. And so we can only imagine how other issues are going to be dealt with. And so those are some of the motivators for the book. In the book itself, drawing on the work of many people, whether they're scholars or activists or based on just people's testimonies over the years and decades, I kind of frame, I guess, medical colonialism in a way to be able to make it useful to understand in the current context. And so I kind of term it as a culture or ideology rooted in systemic anti-Indigenous racism that uses medical practices and policies to establish, maintain, and or advance a genocidal colonial project. And I use that term very intentionally. And half of the book basically, kind of talks about the campaign, and that's the thread that weaves throughout. But one half of the book is really talking about a history of medical colonialism rooted in genocide. And the chapters in this section on medical colonialism are basically divided according to Article 2 of the United Nations Convention on the Prevention and Punishment of the Crime of Genocide. And there are 5 acts which constitute genocide. In fact, you only need 1 act to constitute genocide. And basically each chapter is divided according to the 5 acts, and in each of the chapters, I provide, sadly and disturbingly, a plethora of examples, wide-ranging systemic examples where medical violence was inflicted on Indigenous children specifically. And so I don't have the time to go through all of those examples, but sadly and again shockingly, there's no paucity of those examples. One of the themes or lines that comes back in the book a few times is this idea that inequalities in healthcare follow the fault lines of societal injustices. And so long as there are societal injustices, then inequalities in healthcare will obviously persist. And this brings me back to what Linda was talking about earlier in terms of Joyce Echaquan, who was this woman from the community of Manawan, Atikamekw Nation, who died at a hospital in Joliet after being peppered with racist comments, anti-Indigenous racist comments from healthcare workers. And ultimately, I guess the point is that unless more fundamental societal injustices are addressed, these issues are going to keep coming up. And this is a picture of one of her kids holding the picture of Joyce. And the reality is obviously that these have impacts, as Tanya mentioned, with her experience with her aunt and so many other experiences. These have impacts for generations. And so, vertically and horizontally, these violences echo. And we really have no choice but to put an end to this. This is a note from a former pediatric resident who had emailed me a few weeks after the campaign was launched. And she basically wrote saying, supporting the campaign and saying, I can't even recall all the times in my residency that I was in a situation where this policy affected a child I was taking care of. And then she said, we knew it was the rule, we knew it was awful, and yet we just kept going. And I felt like that really drove home this point of complicity, of the active role many of us as settlers in the healthcare system often play in the context of these injustices, systemic injustices against Indigenous people. And so ultimately, one of the fundamental reasons for writing the book, and I mentioned this in the introduction of the book, is basically so that we can no longer just keep going. And so that we actually actively get involved in fighting against medical colonialism and systemic racism to finally be able to put an end to it and work towards decolonizing healthcare. Thank you very much.
Thank you, Samir. Oof, unbelievable. Your last quote, we know it was the rule and we know it was unjust. I think that's how members of CFNU felt when they were working on the campaign for the Georgian Principle. We had testimonies from nurses that work with the family, but it took almost 20 years for it to change. What I do promise, my magicians in the background, your full bio and the information for your book will be in the chat line, but also one of my magicians, make sure you order enough of his book for our board. That's one thing I tried to do at our board, is to bring different topics that we're working on, but it takes more than a position statement. How many position statements do we pass? And it just stays there, looks good on the book. We need actions. We need reactions from these position statements. So They've already received the In Plain Sight report, but they will receive your book too. And now to talk about more dove into, you gave a great segue for Raven, or Dr. Raven Dumont-Maurice, to speak about the Joyce Principle. I was fortunate to have a copy of it. It's going to our convention. We're going to act on it and see what we can do on a pan-Canadian. But Raven, I'd love you to explain to us why you got involved and why this principle is so important, because on that day in September, it made a lot of us sick to our stomach. And we thank the courage of Joyce that day to be taping this incident. Raven, please.
Hi, good evening, everyone. So first of all, I wanted to thank the CFNU for inviting me for tonight. Thank you very much to my co-presenters, Tanya, for sharing such a deep experience, Samir as well, and to anybody honestly working in healthcare, whether you're an MD, nurse, or any part of the healthcare profession. I do recommend reading the book. It covers in immense detail the idea of medical colonialism, and I learned a lot by reading it. I'll just start by acknowledging that the land that I'm currently speaking to you from, the land that I work, live, and play, is on the traditional unceded territory of the Kanien'kehá:ka people. I'm not too far from Samir, whom I know from a long, long time now. Samir was one of my mentors back when I was doing residency. And I will take the time to speak about Joyce's principle, but I did want to take a moment and share a few experiences and use the time and space to speak about my experience in medical school that I feel fits with the topic that we're speaking of tonight, of systemic racism in healthcare, and how medical schools themselves are not spared from this phenomenon that we're seeing. And so I started medical school in 2008, the first year that a program for First Nation and Inuit students in Quebec were allotted 4 extra seats across the 4 faculties in medicine in the province of Quebec. In the pilot year, 3 out of 4 spots were filled. I decided to study at McGill University for many reasons, but language being one, McGill being the English university in Quebec. And that year, I was the only Indigenous person in my med school class. That said, the number of students applying and succeeding in the program has increased tremendously since 2008. I believe we're on the order of about 50 or 60 current and graduated students. I haven't checked the numbers recently, but I believe that's how many we are now. And although underrepresentation of Indigenous physicians remains a reality, I hope that with the increasing numbers, this will lead to changing conversations and concrete change. And thinking back to my medical school and residency training, there were definite moments of overt racism that were more obvious. Things like being dismissed early on rounds. I remember during a nephrology rotation, because the case that we were about to see was a little bit too complicated, and I would never say anything so complicated on the reserve, so I could just go home. I ended up staying, but myself, or we were 7 or 8 people on rotation, none of us sort of spoke up and brought that to attention. It's something that I definitely regret and wish I had the strength to do back in 2010. Other, smaller overt things like asking one preceptor in particular every single day asked me where I had bought my moccasins when they were like regular shoes from Aldo that a student could afford back then. But every single day made it a point on rounds. And these instances were definitely more obvious, but I found sort of easier to tackle because it was easier to separate myself from the events and move on to the next rotation. But the more challenging part as a med student is all of the hallway talk surrounding patient care that would occur and go unchallenged, sometimes daily, depending on the rotation that I was on. Often not directed at me, but so I can't even tell you how many times that I heard sort of comments being spoken about either patients themselves or people taking care of the patients that we were taking care of. And speaking up at the time as a med student or resident was not an option because the margin for standing out in a bad way is so narrow in a program where you're evaluated almost every single day. And I remember residency definitely more clearly than medical school because it's fresher in my memory, but comments that by no coincidence were reported in Dr. Tupel Lafon's report on racism in BC in plain sight were some of the most common racism stereotypes that I'd hear here in Quebec. And I'm not sure if anybody has seen the video that Joyce had posted, but those comments are also echoed in the slurs that Joyce heard before her death. And so it's no coincidence to me. And I mean, if this is coast to coast, and this is in 3 different settings with the speakers tonight that we're hearing, I mean, it's very hard to deny that this is not a systemic problem. Things that I would hear very frequently were alcoholism, assuming often, and again, I speak more to pediatrics because this is where I trained more recently, but assuming that parents, if they were not at the bedside, were drunk at the park. I heard that so many times. And ironically, we just heard about Samir's campaign and the non-accompaniment rule, but many people were not familiar with the rule. And whether it was nurses, med students, MDs, I remember often hearing how people were appalled at how they could let their kids come all this way and oblivious to what was actually happening underneath, but very, very quick to assume abandonment by the parents. Many implications about bad parenting as well. I heard so very often statements like, these people can't take care of themselves. How would you expect them to take care of a sick child is something that I would hear often. And many misunderstandings around funding, the freeloader Indian stereotype as well. I remember one instance again on rounds where comments were made about a patient who had been transported and housed for free and how everything was free, and then sort of turned around and asked me if my medical school education was free. And as a patient myself very recently, I was questioned repeatedly about my drug and alcohol consumption during an episode, during an arrhythmia, for which I was seen in the Emerge. And this was in the hospital system that I spent the last 8 years in, running around the hospitals I was known. And I can't even imagine Indigenous patients who don't have the privilege of knowing the system and how scary an Emerge could be. And the questioning actually only stopped when my partner, who is non-Indigenous, who's also a physician, said, that's enough. And then the questioning stopped, but I had essentially no voice that night. And lastly, as personal experiences that I want to share just to illustrate the extent of systemic racism in certain settings, was during a rotation, so affiliated with 2 universities in Quebec in a camp setting, where, the word, this may be triggering, but the word squaw was freely used. It was actually written on a cabin. Camp leaders wore headdresses. There were powwows. People were greeting each other saying how. And again, there was no outward or intentional malice with that, but the potential for harm and the necessity for education was just flagrant to me. I mean, obviously there hadn't been any First Nation people in this camp probably before. And the irony is that the camp itself was around, diabetes for children, and First Nation kids are disproportionately affected by diabetes. And this would not have been a safe space had an Indigenous patient gone to the camp. And so tying experiences like these to more recent events, we are here, as mentioned, in large part because of the courage of Joyce Echaquan. Joyce, to remind everyone, was a 37-year-old Atikamekw woman from the community of Manawan, north of Joliet. She was a mother of 7, a wife, loved by so many. And Joyce died in hospital shortly after being subject to brutal racist comments by staff at the Joliet Hospital. And in her final moments, she had the courage and the headspace to film the injustice. And in doing so, hopefully she gave us a gift and the will for everyone and the whole system to change. And so following her death, the Atikamekw Nation put forward Joyce's principle. We heard of Jordan's principle that was back pertaining to Jordan River Anderson in 1999. So sort of similarities there. And what Joyce's principle aims to do is guarantee to all Indigenous people the right of equitable access without any discrimination to all social and health services, as well as the right to enjoy the best possible physical, mental, emotional, and spiritual health. Joyce's principle requires the recognition and respect of Indigenous people's traditional and living knowledge in all aspects of health. And so there are 6 main pillars, and within each come recommendations. For sake of time, I won't get into the recommendations, but it's exceptionally well done, exceptionally well to understand. And I'd invite the listeners tonight to consult Joyce's principle. And so following Joyce's death, the Atikamekw Nation, the community of Manawan, presented Joyce's principle to the Quebec government. And the government refused to adopt Joyce's principle, mainly on the basis that the current Quebec government still does not acknowledge the existence of systemic racism in Quebec. Of note, the current government does not deny the existence of systemic racism completely, however. So I've heard, the Premier acknowledge that it exists elsewhere, as in the US, for example. And this conversation is maintaining, despite everything happening from coast to coast and stories continuing to happen in Quebec. And they followed as recently as this month by saying that they were ready to work with Indigenous people on the issue of racism, but continue to disagree on the fact that racism is not systemic. The CAC and Premier Legault have acknowledged the existence of racism and racist people in Quebec, but continues to disagree that systemic racism exists, and so there's this divergence that will, in my opinion, continue. And it contrasts starkly with the federal government, following meetings in late January with Indigenous health leaders, various levels of government, providing funding, $2 million to directly support Joyce's principle. And these funds in support of the principle are really, getting mixed up in my papers, trying to stay on track and stay on time. And it's really to combat systemic racism in the healthcare system. And from ICS, or the website ISC, with this funding, the Atikamekw will be able to develop tools and training, promote Joyce's principle to healthcare professionals, educate First Nations on their rights when using the healthcare systems. And these funds will also be used to organize meetings with non-Indigenous peoples on fighting racism. And so very, very stark contrast between the levels of government there, which makes it ever more confusing on this issue, in my opinion. And following the meetings, there were other announcements made, namely a national consortium of Indigenous medical education. Minister Haidu announced $4 million for the education of medical students. So that will be to come, and see how that can impact change. And just to close, I think it goes definitely, the healthcare system is composed of, there are doctors, there are nurses, and beyond. And I make a strong pitch for education to start earlier pertaining to Indigenous issues, kindergarten to grade 12, certainly, but also at, not just medical schools, but all levels of education. And in closing, I just, definitely hope for change, and that eventually the government will adopt Joyce's principle. Thank you for listening.
Thank you so much, Raven. Part of the early education, I think I heard children in your background. Cindy Blackstock wrote an amazing book about, she's on to her second one, about Spirit Bear. And I think it's important for us to look and hear the stories and start with our children. But to encourage you about the Indigenous representation in medicine in Alberta, now conservative, deep conservative Alberta, for the Medical Association.
Is it just you and I?
Is it? No, I think we're live. Eh? Nobody's sending me a note. Yeah, we're live. Where all four of us are on the screen and we're live. But Raven, to encourage you, two of the candidates for the Alberta Medical Association are Indigenous physicians. So, and great leaders in their communities. I know one personally. So, it is out there. Our Tanya was president of the, not Alberta, Association of British Columbia Nurses. That was a challenge by itself, but she made it. She have it on her CV. So, quite interesting. We don't have time for a question, which that's what I'd said at the beginning. And it is okay, because I wanted to let you to have the time. These are so hard topics. I was texting back and forth with my son before the session was starting, and I said, Alexandre, I'm nervous. Next March 1st is our next Facebook Live, and it's on pharmacare. Pharmacare is easy to talk about. It is not about systemic racism. It is not about what myself, my family, or my colleagues did wrong or put the blinders on. We can point the fingers all we want at Premier Legault, and I love to point the finger at Premier Legault for many, many things. But the reality is it's a society issue. And the reality is, as Tanya said at the beginning, we need to know when to stop. We need to know how to handle racism behavior for Indigenous people and for many, many others too. And how do we deal with it? How do we work on it? I promise all of you, we're going to work on the Joyce Principle. I ask all of you who are very young, ambitious, and full of energy, don't quit, because it takes a long time. I look at the Jordan Principle. As I said, you know, it was 20 years. I did a session talking about that principle just recently. And I was saying, oh, he'd be about 12, 14 years old right now. And then I had to go back and think, oh my God, 1999. You know, it takes a long time for society to realize what is happening and to admit that we were wrong and to put pressure on politicians to change. So I thank the three of you for your time tonight. Sorry I couldn't come back to you, Tanya and Samir, but no, we'll do more of these. So as I remind everyone, March 1st, 6:30 Eastern Time will be our next Facebook Live, and it'll be on pharmacare. And if you think fixing racism in healthcare is a long topic, so is pharmacare. We've been on this campaign for 20 plus years. So I know you can't do it out there, but help me through the comments, etc. Thank our three guests. Everyone, please stay safe, stay strong. Remember the public health guidelines. We're not out of this pandemic, far from it. And we're going down the second wave, but it's still so important to wear our masks, to wash our hands, to stay the 2 distance apart from each other, limit your gathering, limit them to almost none, but connect with people. Make sure that your loved ones, your friends, your neighbors know that you're there. So thank you, everyone. Stay safe. Bye-bye. Merci beaucoup.